1 second.
Oh, okay, sir. Good evening, everyone.
Good. Good evening, Professor.
Okay.
Okay, and we have
There's an echo.
welcome.
Dr. Russell, I think your phone, are you on both? There's an echo from
No,
you.
you can just mute
No,
it.
I'm not.
Just mute the other.
No, I'm not on anything here.
Your phone? Because there's
No,
an echo.
Jane's.
No, not here. Another room.
No, maybe somebody else. I'll just check.
Just
Not
check.
me.
There's an
I'll
echo.
just check. I'll mute the others. Yeah.
Oh well, a very good day to all of you from Good Morning in USA and Brazil and Argentina. Good afternoon to London and Portugal. Madalena from Portugal, and good afternoon to our friends from France and Germany, and from Africa, from East Africa and Israel, and then all of you from India, and our good friends from Hong Kong and Malaysia. So very welcome to all of you, and then to Des and others from Australia who are here. So we have around the world meeting today, and I welcome you to this 20th webinar. As you know, we've been running these very, very important and interesting webinars. Here we have also from Sri Lanka, our Haris Chandra and so forth. So welcome to all of you. Now, today is very interesting that we had, you might remember, we had a webinar which some weeks ago, which was a panel discussion on the mental health issues and so forth. But this time it's presentations on more specific, so we'll be able to have a deeper insight. And I'm delighted to bring to you a very distinguished panel from around the world. Can I request those to have your mute your microphone so that please do that. We'll really appreciate that. Yeah, so we have a very distinguished panel of psychiatrists from around the world, and I'm delighted to meet you from down under, and I want to introduce Professor Shabir Aminullah from on top of the world. He's talking to you from Ontario in Canada, and I'm talking to you from Melbourne, Australia, down underneath the globe. And we have with us Dr. Sujoy Mukherjee, a psychiatrist, a very senior psychiatrist, a clinician from United Kingdom. And then I have Professor Prabha Chandra, who is another very senior, universally known psychiatrist from NIMANS, who's going to be on the panel today. And we also have who chaired the last mental health meeting, which is Rajiv Tandon, part of the committee, part of our organization. Sorry?
Some other thing on Dr. A.K. Singh.
Yeah, so
okay, go ahead. Yeah.
Okay, so Rajiv Tandon from the chair from Western Michigan University in Kalamazoo will be joining us too. And I have also one more person who's going to be who's also part of our program, but only just earlier told me he was joining us, is Professor Jean Frutos from France, from Lyon. He's a psychiatrist doing work there with the COVID patients, and he was previously on our program, and so he's going to join us later too. So with this, I just briefly would tell you that the UNESCO chair in bioethics, who's the Department of Education that I head, has 250 odd centers, around 58 countries in all the 5 continents. So this initiative is something that the Department of Education has been organizing very successfully for the last 20 weeks. So now I'm going to hand you to Professor Mary Matthew, who is the co-chair of the UNESCO program that hosts this international panel discussion. Over to you, Professor Mary Matthew.
Thank you, Dr. Russell, and good morning, good afternoon, and good evening to everyone who has joined in. Today we have a very exciting webinar, but with a different pattern. We have speakers who will be telling us on speaking about specific topics in mental health issues. And I think it's a burning issue right now. And everyone all over the world are discussing it's not the question of only coping, but what is the residue that is left because of this pandemic. And we are very happy to have with us distinguished panelists from all over the world. And we thank you for joining us. Some of you are coming in at early hours of the morning, so we appreciate that. And as always, to the participants, please feel free to put in your questions in the chat box. And Dr. Derek will be giving you the house rules. And thank you as always. And Dr. Derek.
Over to you. Derek, unmute yourself, please. Colonel
Yes.
Professor Derek D'Souza.
Yeah, thank you, Dr. Russell. Thank you, Dr. Mary, and welcome to the panelists and all the participants. Good to have you all back and looking forward to another evening of stimulating discussion. A small request, other than the panelists who are speaking, we'll request you all to keep your microphones on mute so that there is no background noise and we can enjoy them speaking clearly. Secondly, you can, other than the panelists, again, a request to keep your videos switched off. This reduces the bandwidth and allows each one of us uninterrupted transmission. Otherwise, sometimes there are technical difficulties. I have also put a YouTube live link in the chat box. So for those of you who have colleagues who may be interested and haven't been able to register, you can just send them that link. And especially for those for whom the time schedule, again, is not too convenient, you can send them the link and they can watch it later on because it will be recorded there as well. Again, a small request to our panelists, in case you have any interesting documents or guidelines that you would like to share with the participants, you may kindly put that into the chat box as a document link, because in the past, they found that very useful as a background reading or further reading, because it may not be possible to go into every discussion at all times. So with that, I hand you back to Dr. Russell. Sir, please take it away. Thank you.
All right, thank you, Professor Derek. And I want to, before we go further, let me acknowledge the international committee that has put this together. We have, of course, all of us here, but we also have Dr. Animesh Jain, Professor Princy Pelleti, Professor Geeta Lakshmi, the Vice Chancellor, and all from MGR University, and Dr. Joe Thornton from USA, Dr. Stacy Gallen from USA, and Professor Gerard Fortwinkle from Hanover, and we have Des Cahill from RMIT University in Melbourne. All are here online, and Baroness Elora Finlay from Professor Baroness Elora Finlay from United Kingdom, who is part of this program. So we will now hand over to, I will now introduce to you our first speaker, the distinguished speaker is going to present to us is Professor Prabha Chandra. Professor Prabha Chandra is a very senior psychiatrist. She was the former head of psychiatry at NIMHANS in Bangalore, one of the internationally renowned psychiatry and neurology centers in the world. And I'm going to hand over to Dr. Prabha to, before I do this, I want to also acknowledge Professor Shabir Aminullah is the leader today. He leads, while I chair this session, he leads this whole program today. He put it together, and he will be speaking to us. Before we start, Dr. Shabir, is there Professor Shabir?
Yes, I can hear you.
Yeah, do you want to say a few words as the lead to today? Dr. Prabha, we'll just ask Shabir as the lead whether he would like to address the participants. Professor Shabir is from London, Ontario, University of. He's affiliated with two universities, the Dalhousie and the University of Western Ontario in London, Ontario, in Canada. Yeah, Shabir, do you want to?
Thanks. Thank you, Russell. I'll keep it very brief because we have quite a few speakers today. But really hats off to Mary, Derek, and Professor Russell D'Souza for actually putting this together. This is the 20th such webinar they've put together, and attendances have varied from 800 to 1,000 and more, and excellent discussions. For me, this is particularly important because Prabha Chandra, when I joined NIMHANS for my MD, was one of those who were really my mentors, and still is actually. And I still ask her questions about management in perinatal postpartum care. And she's without doubt one of the nicest people I've worked with and a truly amazing consultant. With that, I hand over back to you, Russell. Thank you.
Yeah, thank you very much, Shabir. I have Dr. Prabha. I'm very aware of your eminence, and we're delighted to have you here speaking to this very distinguished audience. The importance here is that we have people, our colleagues from around the world, representing the world here, from North America, South America, Africa, East Africa, Asia, and Europe. So welcome, and over to you.
So much, and thanks Professor Russell D'Souza, Professor Derek, Mary, and Dr. Shabir for inviting me for this program. And it's so delightful to see people from all over the world sort of logging in. I think if there's one thing good which has happened because of COVID, it's the fact that we are linking with each other much more online. I'm going to talk about a topic that is really dear to my heart, and that is maternal mental health. Trying to kind of take you through this whole area of how COVID has affected maternal mental health, how it might affect maternal mental health and infant mental health in the future, and what, as mental health professionals, as people who talk to obstetricians, nurses, other frontline workers who deal with mums and babies, what is our role? What do we need to do? So in the next 15 to 20 minutes, I'm going to take you through this journey. There is not too much out there. There is, there are surveys which are being done, there are commentaries which are being written, there are case reports, there's experience, but I think the solid data is still not completely available, particularly data on women who are already positive and their babies. And I think that's an area which we really need to look out for. So let me share my slides with you and sort of get on with my presentation. Okay, so I really want to start with the fact that the relationship between viruses and childbirth and maternal mental health is really not new. Viruses have been connected with maternal mental health for some time now. And I've just taken the 4 important ones, including COVID, and the first one is Ebola. We knew that Ebola in West Africa actually caused a lot of increase in sexual and gender-based violence. There were twice as many rapes and a sharp increase in pregnancy rates, and which obviously had a lot of mental health implications for the young girls and women in West Africa. We also know the role of HIV in maternal mental health, and there's been a lot written about it. The fact that young girls are more vulnerable. There's strong links between gender-based violence and HIV. And we all know about vertical transmission of HIV and, to the fetus, and the enormous impact that it has on the mom. Because very often for mothers, that's the first time they get to know about the fact that they had HIV, when they come to an antenatal clinic and are routinely tested. Much more recently, Zika virus from South America, which we know disproportionately impacted pregnant women and girls, and the implications for the fetus. So, there's been a lot of literature on the mental health of mothers who had Zika virus. And now, of course, we have COVID-19. So if you see historically, and even prior to this, viruses and maternal mental health have a very, very strong link. And we can't escape it. With COVID-19, there have been already some reports, like I said, of high rates of pregnancy-related anxiety and perinatal anxiety. These are reports initially from China, but subsequently from various parts of the world, including Sri Lanka, Bosnia, India, the US, Canada, a large number of reports coming in, basically talking to moms, especially who are pregnant, and trying to understand what they're going through. So let me tell you a few stories. And these are, because ultimately, as mental health professionals, it's all about stories. It's all about the patient narrative, what they're going through. And I've sort of compiled 4 stories for you for women whom I've been helping, who've come to me, and trying to sort of show you the range of issues which can come up. So here's 31-year-old Supriya, who I'm working with, psychologically providing therapy. She's a surgery resident who's currently 4 months pregnant. She had an MTP in her last pregnancy because of the fetus had a heart condition. So she's extremely anxious because of the possibility of infection and concerns about fetal health. Recently, a patient of hers turned COVID positive, and her anxiety has escalated immensely. And she's really been struggling with this anxiety. We now go to 27-year-old Meena. Now, Meena owned a school and planned this pregnancy because she thought she was, financially in a stage where she could have a baby. And now she's in financial crisis because all the schools are shut, and she hasn't got the school fee that she was supposed to get in the beginning of the term. She's in her 8th month of pregnancy and came to us because she was unable to sleep, feels extremely depressed, and is occasionally suicidal. I'm actually helping her almost with daily calls, and as I speak, she's going into labor, and I'm hoping that once she goes into labor, she'll be a little more calmer. But this has been a very, very challenging time for Meena. Then we have 25-year-old Padma, who was detected to be COVID-19 positive just before labor. So we know that women are tested just prior to labor so that people can take precautions. We can take precautions about the baby, and this is a routine protocol. She was removed abruptly from her family, whisked away in an ambulance to the hospital, all alone, had a C-section, and her baby was kept in the nursery away from her, and she was not allowed to breastfeed. She felt fearful, restless, and started having delusions of persecution, and she was brought to our emergency with postpartum psychosis. Now, and I'm going to talk a little bit about the protocols that various hospitals are following and what we need to do when we have a mother who is COVID positive and what are the kind of precautions we need to take. But this was clearly a very, very traumatic time for this lady, particularly because she was all by herself. So we all know that now pregnant women, when they're in the hospital, they don't have a support person. Because of the risk for infection to others, risk for infection to the other moms and babies who are there. So these women are all by themselves. And we all know that particularly in many, many cultures, South Asian cultures and many other cultures, African cultures, the time of childbirth is the time when the family is around you. You're never left alone in a hospital to manage yourself and the baby. But unfortunately, because of COVID, Most moms are just by themselves. And if you're COVID positive, then the isolation is even worse in the hospital. And this can be an extremely traumatic time. Finally, we have 35-year-old Priya. She's a school teacher. She delivered a baby 2 months back, but she left her home because of mental torture and partner violence in her joint family. Her parents will not have her either because of fear of COVID, because they feel you're coming from another family to us, we are elderly, we have other kids, so please don't come to our house because we are scared that you may bring us infection. She's too scared to go to a shelter because she's worried if her baby and she would get infected there. And we know rates of domestic violence have escalated sharply in most parts of the world. And we know that perinatal violence is another major risk factor for poor mental health. So I think these 4 stories, very different range of women, very different range of mental health problems, but kind of exemplifies to you what are the kind of challenges that mums are dealing with in the context of COVID. So just to give you a sort of broad idea, like I said, there have been surveys using telephones and using online surveys, some of them, very few of them face-to-face with mums in pregnancy, and rates of anxiety have sort of ranged in the whole world between 25 to 30%, depending on what tool you use, depending on what measure you use, but it is there. So what causes perinatal stress, anxiety, or depression in mums? It's first of all, it's fear related to the virus itself. Will I get disease? Will I die? Concerns about transmitting infection to the fetus of the baby. This is like extremely high on the list. Concerns about going to the hospital to get antenatal scans. So a lot of moms are actually not going to hospitals because they're scared that they might get infection by going to the hospital, so hence neglecting or delaying. And this is particularly a problem in women who have high-risk pregnancies, who are expected to get their scans done in time. Social isolation is leading to poor social support, and we know that's true for all mental health issues, for all people. It's not unique to maternal mental health, but we also know that it takes a village to raise a child. We say it takes a village to be with a pregnant mother and to be with a mother who's having a little baby. So social isolation is particularly a big problem in this situation. Relationship conflict has been a big issue, like I mentioned in the slide previously, because of close proximity. And world over, domestic violence rates have increased. And what is more challenging is that women are not able to disclose partner violence. So all of us who are working in perinatal mental health know that one of the biggest problems and biggest risk factors for postpartum depression or antenatal depression and anxiety is relationship conflict and domestic violence. And unfortunately, in a situation where the abuser is at home with the mom, she's not able to even reach out or call helplines or seek help because she's not able to disclose partner violence. And of course, like I showed you in one of the women who got help from me, there's financial insecurity, food insecurity, housing instability. And the mothers say that this is not what they bargained for. When they decided to get pregnant and want to have a baby, this was not what was there in their agenda. They all wanted to sort of were thinking of a happy baby, and then March came and suddenly everything just completely changed. So a large number of women are reporting stress, anxiety, and depression. And why is this so important? Of course, the mother's suffering and the mother's dealing with all this, but we also know that when 9/11 happened, or the Quebec storm happened, or when there were cyclones or floods, we know that prenatal stress, the moms who were pregnant at that time, the effect of high cortisol levels during pregnancy have an impact on the baby's development, including the neurodevelopment, the socio-emotional development. And these babies have been found to have problems compared to babies who did not face this kind of stress. So I think the nature of stress which COVID is posing is something which we really don't know enough about. What kind of stress is it going to cause to the baby? And it's only time which is going to tell us what's going to happen. I want to emphasize the role of obstetric and reproductive violence related to COVID. And I want to highlight the fact that during lockdowns, there has been a lack of availability of contraception. So government clinics, which normally give out free contraception, in many countries were shut because they were not able to provide contraception. Hence, there have been a lot of unwanted pregnancies. Medical terminations have not been available because, again, services were shut, and for a small period of time, I think that it was about for 4 weeks or so, at least in India, that you did not have a possibility of getting a medical termination. There has been a lot of concern about lack of care during labor, particularly in the early days, because the staff was very scared of acquiring infection. There was not enough information available. And in many places, there was a lack of transport during lockdown, so moms were not able to reach the obstetric services very easily. So these sort of constituted many forms of obstetric and reproductive violence. And I think a lot of, like in the case of Zika and Ebola, there were unwanted pregnancies. Here, the unwanted pregnancies for very different reasons. This is the mother who had postpartum psychosis who says, I was whisked away in an ambulance, alone to the hospital. My baby was taken away for 5 days. I was alone after a cesarean section with no one to help me. I still get nightmares and can't bond with my baby. So I think I view COVID-19 in pregnancy and in the early postpartum as trauma and it causing psychological injury to mothers. There have been lots of situations where pregnant women are not being accepted in hospital that look after patients with COVID infection. So you have COVID designated hospitals. Mothers might have registered in these hospitals earlier. We're going to see the obstetrician there. It was a familiar place, a friendly place. And now suddenly these hospitals have become COVID hospitals. And they are no longer allowed to go into these hospitals. So they have to go to hospitals other than where they register, to a completely new environment, new midwives, new obstetricians. And that's extremely traumatic. And we all know what it's like for couples and for mothers to go to a completely strange or a new obstetrician just around the time of labor. There is also a perceived lack of care during labor. I say perceived care because I think mothers have told me that everyone is in PPEs. We can't recognize, we can't make out who the obstetrician is. We can't make out who the midwife is. We don't know who the nurse is. We don't know what they are doing to us. They all look very strange, and it's not at all familiar, and it's quite difficult to communicate. So there is a perceived lack of care. Mothers are alone after childbirth, which I think, like I mentioned earlier, is very hard. There's lack of transport during lockdown. And a lot of women have reported a perceived lack of empathy from healthcare professionals in obstetric settings. And, in our recommendations, I'm going to talk about what we need to do about this. So this was a survey that we recently did among obstetricians about the concerns and anxieties that women express to them in the perinatal period. And I've just listed some of the top anxieties and concerns. This was with the Royal College of Obstetrics and Gynecology in South India. We surveyed 118 obstetricians in the early parts of the pandemic. There was a lot of anxiety related to excessive social media messages, which was scary. There was significant anxiety and worry about the infection, distress due to boredom, because a lot of them were feeling isolated, feeling distress due to missing work. So many mothers, like to work till the end of pregnancy so that they can use their leave when they are after they have their baby. And many of them had to miss work because they couldn't go to work. An interesting aspect that we found that mothers were missing out on was a lack of childbirth-related rituals. So they didn't have baby showers, they didn't have the celebrations which normally happen in many cultures in pregnancy and once the baby is born because of social distancing. And for a lot of women, this was like a loss. It was like a grief that they didn't go through something which was so important to them. Mothers were concerned about hospital visits for antenatal visits and scans. About methods they could use for protection. Particularly, there was a lot of concern about sanitizer use. So even though we were telling moms to use a lot of hand sanitizer, they were worried what impact it would have on the fetus. And then there came some literature on that, after a lot of research was going on. Safety of infection of the infant from infection after delivery, effect on the unborn baby, effect on pregnancy outcomes, including whether they're going to have a cesarean section. So initially, in the early days of the pandemic, there was a lot of talk about not having a normal delivery and doing a cesarean so that the chances of any infection would be less. Of course, this was not done later. And the safety of breastfeeding. So all of these were concerns that obstetricians reported that their patients and the spouses and partners had spoken to them about, but obstetricians also talked about their own concerns and their own stress, and talked about how they needed support and help and training to actually address some of these problems. And to do that, we actually had started running courses, certificate courses on perinatal mental health for obstetricians and obstetric nurses so that they can manage some of these issues on their own. So these are some of the things that I think we need to sort of think through when we're talking about maternal mental health. So let's have a look at which mothers are at higher risk for mental health problems. I want to start with communities because I think these are important. So these are underrepresented minority communities who anyway don't have the agency or not empowered to talk about what they want. We know there's been a lot of migration issues and border issues in relation to COVID. So communities with undocumented immigrant residents, communities with limited access to technology and healthcare resources. And I bring this up as a highlight because every time we talk about, having to do teleconsultations and having to, use video calls, but we tend to forget that there's a large group out there who may not have access to technology and the internet. And of course, communities that experience housing instability or homelessness. So these are women mothers who are at high risk. The other group is mothers with high risk pregnancies, because as it is, mothers with high risk pregnancies who have gestational diabetes, a previous neonatal death, hypertension, PET, their levels of anxiety are usually higher. And in a situation of COVID, the anxiety really escalates. Mothers with pre-existing mental health problems, and we've had to actually shut down services because it was considered risky for people to come in. So our perinatal mental health service had to be shut down for a period of 2 months, so these moms could not access us. Mothers whose infants had been separated, either because the baby had a problem or because some obstetricians continued to actually separate mums and babies, even though there was a quite strict policy, and the fact that WHO, as well as many other organizations, had said that there was no need to separate the mother from the baby, but some obstetricians continue to do that. And of course, like I mentioned, mothers with poor support systems and partner violence. Are we expecting a PTSD epidemic in mums during in the perinatal period with COVID-19 as trauma? I think we might. And we're already seeing that, and particularly some women who've lost their pregnancy during this period. If the COVID care infection, if the COVID related care was perceived as traumatic, like I give you an example, delay or denial of obstetric care near a childbirth. And I really must emphasize that this was a huge problem, at least in the months of March, April, and June and May, when mothers all over the world, because of lack of knowledge among health professionals, did not know what was going on. They were shunted from one place to another, especially near a childbirth, and bonding problems because of fear of transmitting infection and not breastfeeding. So mothers have told me that they are so scared of bringing harm to the baby that they'd rather not breastfeed or they give care to somebody else, and this has been causing bonding problems. So what are the recommendations? My last few slides. I think the important thing, both prenatal and intrapartum mental health support recommendations include, we need to be advocates for pregnant women, to have an emotional support person present, and try and provide women-centered care even during telehealth visits. Provide education for families on the latest evidence on how COVID-19 affects pregnant women and infants, so that they are not stigmatized and they're taken care of. It's very important to assess for pre-existing mental health or substance use disorders and connect women with mental health services early in pregnancy. We know that world over what has happened is that there's been so much emphasis on COVID-related services that resources for non-COVID services have come down. And this can cause a problem, like I mentioned earlier, screening for partner violence, and acknowledging to the mother that birth in a pandemic is not what the mother had planned for, and that feelings of anxiety, grief, and fear are normal. So I think just that empathy is extremely important. I would also like to focus on shared decision-making that center on women's values to optimize informed choices, promote control and choice to the greatest extent safely possible to minimize power dynamics and the potential for re-traumatization, particularly in systems, because if any of us have gone for care now, we know that even the system is so traumatizing. At every step, you are faced with people whom you can't identify, and for moms this is very difficult. Try and explore how the woman's birth experience can be made memorable, even in light of social distancing. So trying to have some sort of rituals through videos, through other methods, celebrating the motherhood in some unique and innovative ways, assessing for COVID anxiety, and trying to use positive health behaviors and positive cognitive reframing. Postpartum mental health support. I think the important thing is to facilitate technology-based mechanisms for family and support person interactions. I know that a lot of mothers use their own WhatsApp and their phones and things, but I think it should be a systemic response. The Royal College of Obstetrics, the Royal Hospital in London for babies has actually developed a beautiful video app. So if the baby is for some reason in nursery, in a very safe manner, the mother can actually interact with the baby, and it's facilitated by the hospital and through technology. So I think we really need to do that and not rely on the mother's own technology resources to do it. Avoid separating mothers and infants unless required by clinical condition. Promote skin-to-skin contact and breastfeeding to the extent safely possible. And I think it's very important that while we're thinking of mothers, we need to think of the infants also. So for some reason, if infants are being separated, I think touching, stroking, human touch is extremely valuable. The voice of the mother, encouraging the mother to record a lullaby that you can play to the baby in the nursery. I think these are small things that one can do to enhance the infant's mental health. I think upon discharge, it's very important to evaluate the psychological symptoms and support systems, and even reach out to grandparents, because they may have some unique ideas, or the partner may have some strange ideas about COVID and coming in from hospital, etc. And trying getting in a behavioral health consult as soon as possible. So what may contribute to better infant health? So I think there's been not enough attention being paid to infant mental health. The World Association for Infant Mental Health, the WAIM, has brought out quite a few resources, and I would encourage people to read them. There's been, talk about how you can use touch and stroking, rooming in by keeping social distancing, encouraging mothers how to wear a mask and continue to breastfeed, frequent developmental assessments. I think these kids need to be followed up, and there's great potential for research here for whoever wants to follow up a cohort like this, and trying to ensure attachment using play, talking to the mothers about maternal sensitivity. So when a mom has gone through so much trauma during delivery, she might be so absorbed in herself that doesn't have the opportunity to learn maternal sensitivity. So talking to moms about maternal sensitivity, how do you respond to an infant without getting scared, without getting anxious? How do you use fathers and grandparents? How do you teach a baby to self-soothe and try to normalize sleep patterns? Because an anxious mother, we know, finds it difficult to soothe the baby and to make the baby sleep. So these are some areas that I think require interventions, and I think perinatal mental health professionals and obstetricians and neonatologists, pediatricians need to work together for this cohort of very special babies who are either born of mothers who had COVID-19 or were just born during the pandemic. And the fact that they had to come out into a world which was so different from what their parents had imagined they were bringing them out into. So I would also like to kind of touch upon this group, and I think we almost always forget them. And these are women who are going through fertility treatments. Again, there is loss and grief, because the society, for example, the American Society for Reproductive Medicine has recommended, and this has been all societies who are working with fertility, to stop the initiation of any new treatment cycles, ovulation induction, IUI, IVF, strong consideration to suspend all embryo transfers at the fresh or frozen. Now, can you imagine? People had planned, they had taken hormones, they had spent a lot of money, and now there's age which is going on, they don't know when this is going to end, and suddenly all the fertility treatments are on hold, and there's a sense of absolute vacuum for many of these couples. And I think we really need to help these potential mothers and fathers in managing and navigating this loss and disenfranchised grief. There have been several global initiatives in perinatal mental health support. Many organizations have started perinatal mental health, dedicated mental health helplines, and the numbers of calls we receive are enormous. There's aggregation of resources with several OB/GYN organizations and the International Marseille Society for Perinatal Mental Health has a lot of resources which they've gathered together, available on their website. Many organizations have been using training obstetricians in handling common mental health problems. I did a webinar last week. I was telling Shabir for the Obstetric Gynec Society of India, and 890 obstetricians joined in just to learn about mental health, because it's so important for them in this stage. And we really need to work on preventive interventions for mother and baby and start quite early in the hospital itself. What should be the research priorities in maternal infant mental health? For those of us who are watching, who want to think of what research we can do, I think it's important to use population-based data sets to better understand the effects of COVID-19 on early childhood mental health outcomes, including the effects of separation and social distancing. Like what does the baby react to social distancing and masks? You know, the baby can't read expressions. And we know the important thing for an infant is the to and fro dyadic interaction. So what's going to happen to these babies who are seeing everybody in masks? Documentation and development of interventions to address disparities in mental health outcomes. And I'm particularly interested in looking at local solutions that many countries and many organizations are developing. And these need to be written out as case studies so that we can learn from each other, because this is a completely new area for all of us. Like, none of us know anything. So learning from each other for me is very important, and trying to understand how we can help these mothers and children. Evaluation of telehealthcare models as an intervention to improve access to perinatal care. Development and testing of virtual social support interventions to promote maternal mental health and positive early parenting, because all parenting interventions, including in countries like the UK and Australia, have always been face-to-face. Now we have to change it over to the circle of security. All of those interventions that we know world over are going to change into virtual platforms. We don't know enough. And I'm particularly interested in looking at stress of obstetricians and obstetric midwives and frontline healthcare workers in these settings, because they are grappling with a lot of unknowns themselves and have to help the mums and the babies. So I really like to thank all of you to give me this opportunity to talk to you. These are my key resources. There are many resources out there, but these are 3 articles which I thought were wonderful, and I'm happy to share them over the course of the talks. And also the Marseille Society. This is the perinatal mental health resource, which they've got a huge resource, and those are my coordinates if anybody wants to get in touch with me. Thank you so much.
Sir, you have to be on.
Thank you. Yeah, thank you very much. I'm sorry, I was muted. Professor Prabhachandra, for that illuminating presentation and lecture, particularly in this area, which I think, having listened to it, I think it's quite a difficult area considering the current situation. I guess many of us might not have realized the impact it has in terms of perinatal, and I was even more astonished with the effect on the assisted reproductive technology areas, which you rightly have said could be very devastating to many people who are very keenly looking forward to that. Yes, I think it was a wonderful talk and wonderful opening for all of us. Now, Professor Prabhachandra has given you some resource material, and I think she might put that up for you. Welcome to all the participants are welcome to put your questions there. And at the end of this program, we are hoping that we'll have an opportunity to bring you in, for some of you, with your questions, to be able to put it to the presenting the panelists here and get a chance to directly discuss it with either of us here. So thank you very much. And now it's my great pleasure to bring on our next speaker and who's going to present to us, Dr. Sujay Mukherjee from the United Kingdom. So Dr. Sujay Mukherjee is a senior consultant, or in fact, old age psychiatry consultant and is currently with the West London National Health Service Trust. And he's a member and associated with the geriatric psychiatry, not only of United Kingdom, but of the European group. And I'm very happy that he has joined us today to enlighten us, in particular all those who are part of the UNESCO program who come in here. And today, Dr. Sujay Mukherjee is his topic is going to be COVID-19, mental wellness in the elderly. So, Dr. Sujay, over to you.
Thank you very much, Professor D'Souza, and thanks for inviting me and giving me this opportunity to talk. And also my sincere thanks to Professor Matthews and Professor Amanullah. My name is Sujoy Mukherjee. I'm a consultant psychiatrist, old age psychiatrist. I work in West London. I've been working here for a long time. As Professor D'Souza said, that I'm also involved with the executive committee of the Faculty of Old Age Psychiatry in the Royal College of Psychiatrists, and I'm General Secretary of European Association of Geriatric Psychiatry. I'm also a tutor in medical ethics and an examiner for Imperial College London. And thank you very much to all of you for joining this webinar, and it was an excellent presentation by Professor Chandra. Now, if I may share my screen with you.
Yeah, go ahead.
Right, sorry, I need to go to the. It's not going to the beginning.
Just click on slide 1, sir, where you can see.
Yep, I'm here there.
And then yeah, perfect.
Can you see it now?
Go ahead, sir.
Sorry about that.
Yes, very nice.
That's fine. That's fine.
So first, what we are going to talk a little bit, we are going to talk about the COVID-19 and its impact on the elderly population. Now, obviously, we have to remember that the term elderly can be interpreted in very different ways. And we generally sort of take a cutoff of 65 years as, differentiating between adult general population and elderly population. But obviously, what we know, that it's not a homogeneous population we're talking about, because you could be above 65, you're fit, healthy, and working, whereas some elderly could be very ill, has a lot of comorbidity or frailty. So this is not a homogeneous population we're talking about. But looking at how the population is spread across the world, we know that Japan and Italy are two countries with the highest proportion of elderly people. In Japan, it's about 28%, and Italy 22%. USA 18%, UK 18%, USA 16%. Compared to that, China and India has a relatively younger population. As we know, in India, only 6% of the population is over 65. And region-wise, the Southern Europe has the highest proportion of people over 65. Those are the countries, mostly Mediterranean countries. But interestingly, obviously, because of the number, when we look into the absolute number of over 65, that's where China has got 166 millions and India 84 million. So in terms of absolute number, these two countries have the highest population in the world of people over 65. Now, we know that we have seen that COVID-19 so far, which is, mind you, still an unfolding story. We know that the elderly has been disproportionately affected. And when we look at the sort of the UK data, the Office of National Statistics, it shows that about 90% of people who died from COVID-19 are actually over 65. And why is that? We only understand few issues. We don't fully understand why that is happening. But obviously there are issues about comorbidity. This population has got more diabetes, hypertension, cardiac problems, multimorbidity, and frailty. We know a good number of them live in sort of vulnerable care settings like care homes, particularly in Europe and America. The issues around ceiling of care, which we'll be touching upon later on. And also this is a group who has higher risk of developing delirium and they may be immunocompromised as well. So these are some of the reasons why it seems particularly the mortality or severe morbidity is much higher in this group. Now, the care home issue is particularly needs to be looked at. Now, people who are not from our region, I think people have a general understanding what a care home is. It's basically an institutional setting where mostly elderly, not necessarily, you know, there could be younger patients as well for other reasons, but mostly elderly who couldn't live in the community, even with support. They need to go and can you hear me?
Can we request everyone to mute yourselves, please?
Sorry.
Thank you.
So
Yes, please go ahead.
So the care homes, you know, particularly the countries which are most affected, like Sweden, Italy, UK, USA, Belgium, and Spain, there have been a huge number of people, residents in care home who died, and it has become almost a kind of an international outcry, really, what happened. And when you look into it, why this happened in these particular settings, there may be multiple reasons. Obviously, these are extremely vulnerable population. There have been poor infection control, particularly in the earlier part of the pandemic. A lot of these elderly people, when they were getting admitted to hospital, they're being sent back to the care homes without proper testing. So they brought the virus back in the care home where it spread quickly. We have a mobile workforce. That means the carers, they move from one care home to another and they change quickly. So they also brought infection from outside. There was a lack of testing at the beginning. And also we know there was a lack of PPE, which is personal protective equipment. There was a general problem with PPE with all healthcare professionals, and the care homes were, you know, much bottom in the pile, really. So they didn't have adequate supply at the beginning, and that took its toll, and so many people died. And it caused quite a bit of outcry, as I said. Like, you know, there was a social scientist, Jeffrey Players. He wrote in a Belgian newspaper and said almost Belgian society has decided that the lives of these confined elderly counted much less than those so-called actives. And that raised quite a bit of ethical debate, really, that whether we have failed this population. And the other issue was about ceiling of care. And ceiling of care is essentially mean how much care somebody should receive under a given circumstances. That's the definition by Walls et al. Now, obviously, that brings in a lots of ethical debate. Like, for example, during the peak of the pandemic, we know that many Italian hospitals were running out of ventilation facilities. And the question was raised whether there should be a criterion in reaching life or death decisions. So essentially mean who should get to the ventilator. In Spain, there have been a lawsuit going on against the care institutions. Again, the families complaining that their elderly relatives were not really treated. American Psychological Association, Health Platform Europe, they had to come and actually come with a statement saying that we cannot discriminate people based on age. Having said that, you know, in ethically also sometimes it's very difficult, because if you have a defined resource and you have to make a decision between people, you are guided by various factors, and obviously medical factors, which age, you may not specifically talk about age, but it comes into the equation. So these are the kind of the problematic ethical and practical problems which has affected the elderly quite hugely, and particularly people who have been living in the care homes. Now, when we look at the psychological impact of COVID-19 on the elderly, again, you know, we need to appreciate that this is still an unfolding story. Research so far is limited, and there is not huge data specifically for older age group. This recent publication in Lancet Psychiatry, this was actually a detailed analysis from the Rogers et al., which is the UK group. And this is a meta-analysis where they looked into so far published material, and they talked about depression, anxiety, fatigue, PTSD, and some rare neuropsychiatric syndromes. Now, these are not specific for elderly, but we can say, well, many of those factors are very much applicable to the elderly population, but also probably sleep deprivation and various other things. But there need to be further ongoing research to look into the overall impact. And also there's a recent survey done in the UK, which was done by one of the polling agencies, Ipsos Mori, along with Aging Better, which is actually a charity. And they looked into sort of a good number of elderly people. It's a self-reported survey, which showed that about 36% people between the age of 50 and 70. So it's not really elderly, sort of older population. They reported a deterioration in their mental health as a result of the pandemic. So it's quite a substantial impact on the population, on this group of patients, or this group of people. So what are the factors which are affecting the mental well-being in this group? We could look into the few of the factors. One is impact of negative news and also misinformation. Obviously, if you are being told that you are the most vulnerable group and you are the most likely one to die, it's very difficult to be positive about it. But one is about that genuine fear, but also there has been a lot of misinformation, and people are, sort of literally sucking in information from so many different sources, and that doesn't help. Often actually increases the fear and anxiety and apprehension among people. Obviously, people, elderly, are worried about getting infected with the virus, and the stigma of the infection, in particularly certain countries and societies. We read about what's happening in India and many other countries. If you are infected, then you are abandoned by your family, by your neighbors. Sometimes you face very hostile environment around you. So that itself is enough to create psychological trauma or stress among people. The effect of lockdown, physical distancing, containment, social isolation, and loneliness. I put them all together because we know the lockdown and physical distancing has taken away a lot of things which elderly people have been doing, particularly people whose mobility may be limited and who may have a limited ability to go out. And some of them may be going to structured places. Like, for example, in the UK, there have been a lot of day centers for elderly people. Elderly go to the places of religion. There are sometimes community transport arrangements, and that was their lifeline. And suddenly all that is gone. Loneliness is a huge problem. I mean, not only in the Western world, but also even in developing countries, but particularly in the Western countries, there have been a huge focus on loneliness, particularly among elderly, even before the pandemic started. And really the pandemic has made that situation much worse. Disruption of routine and activity, which I've already touched upon, and the reduced family and social support. Now, we know that many elderly, both because of physical, but also for cognitive reasons, their functional ability gradually reduces, even for people who may not have dementia. But if their routine is disturbed and activity is curtailed, they quickly can lose those skills. And that has had immense effect on the elderly, particularly because of this disruption of the routine and their activities. And there is reduced family and social support because obviously family couldn't visit, they couldn't meet. And the social support means, seeing your neighbor, maybe sometimes just waving your neighbor, having little small talks. That makes such a big difference. Because of the social isolation, that was not possible. And in the UK, the government did something called shielding. So that means people who were vulnerable for medical reasons, but also people who are over 70, whether they're vulnerable or not, government basically told them completely to self-isolate, even from their own family if they're living by themselves. So that cut off their external contact hugely. The problem of alcohol intake and smoking, obviously people, when they're isolated, they're anxious, they sometimes might indulge. This is not specific for the elderly, but a subproportion of elderly could have been significantly affected for that. And where the elderly was actually living with family members, we know, as my previous speaker also pointed out, that overall in the world, there has been an increase in domestic violence and abuse. And that has affected the elderly as well, because sometimes there may be not enough space. Family members who are staying together, sometimes they're sort of passing on their difficulty to each other. And particularly the elderly population remain very vulnerable to that situation. So we have noticed an increase in the abuse and domestic violence. And the last bit is what we call digital poverty. So digital poverty, elderly may not have access to digital platforms as much as their younger counterparts. One may be because they never used it. They're not very digital savvy. The other is they may not have a smartphone, or they may not be able to pay for a good internet. So those all kind of factors have affected the mental well-being in the elderly. Now, this list is not exhaustive. I'm sure there are other causes, but this sort of give you an idea about what are the different factors affecting this group kind of disproportionately. And these people who have got particularly cognitive impairment, people with dementia, they have particular problems. One is information overload and confusion. They're bombarded with information which they find very difficult. Sometimes, if they're watching the television or something, they're not making sense of what's going on. They're unable to follow guidelines. So sometimes they're not maintaining social distancing. They're unable to follow the hygiene routine. And thereby they're putting themselves and everyone else at risk. The change of routine, which I've already mentioned before, is causing havoc, particularly people with cognitive problem, because it's affecting their orientation, their functioning. And I've been speaking with some of my colleagues, and the cases we are seeing, the kind of loss of skill and sort of excess or increase in behavioral disturbance in this group of patients are very significant. I'm not aware of any proper research yet, but I'm sure they're ongoing. And I think there's so much need to do some sort of longitudinal studies to see actually what impact and what would be the long-term outcome. Would it improve once we go back to normal, hopefully? Or is this something which becomes almost irreversible? But we can see there's a significant deterioration in cognition as well as functioning of this group, particularly the people with dementia, both in the community and in the care home. Because even in the care home, they're confined to their rooms. And the sort of movement around the care home is much more restricted than before. And as a result, people with dementia is developing suspiciousness, aggression, wandering, all kind of behavioral disturbance are getting exacerbated. And then there is huge impact on the care provision. We know we have switched into telemedicine, and similarly, like other specialties in psychiatry, we are using sort of remote access, things like Zoom, not Zoom in the UK, we use Microsoft Teams and various other software platforms, remote platforms. But this can be very confusing with elderly. Sometimes they're hard of hearing. Sometimes they may not have access unless they're helped by their family who are not there. So it is not very effective alternative for elderly population. There have been limitation on investigation, both for mental health. If we have to assess somebody for dementia, we have to think twice before we arrange for a neuroimaging, because first, for how they're going to get there, is it a risk that they might actually get infection if they go for the investigation? That is limiting our assessment. There has been a cancellation, huge cancellation of medical services, not only mental health, all physical health. There's a limitation of access of care, and there's a general impact on healthcare. And that is causing havoc, because we know mental health and physical health often are related to each other, and particularly in elderly, they're hugely overlapped with each other. And there is a risk of hospitalization, and that's kind of both ways. One way, not to go to the hospital is a risk when you need to, and the other way, there is a risk of being in the hospital because you have a higher risk of getting the infection. So all these factors also has affected the care provision and how we manage people in the community. Now, what advice we can give to our elderly population? Obviously, there is no magic bullet, as you might have imagined. But there is certain general advice I think we can give to people. Obviously, staying connected with friends and family is very important. People who are able, either by telephone or by WhatsApp, Facebook, whatever, or any other of these, video conferencing platforms, any way to keep connected is helpful, because that reassures them. Planning the day is important, because now the problem structure is gone. So where possible, people should be encouraged to make some kind of planning, write a diary, do little things, but make a plan. Avoid too much news and negative discussion. It doesn't help, because some people have become obsessed about all the scare stories, and it actually just fuels the negativity and the anxiety and all the stress. So maybe avoid and reduce the amount of news and negative discussion one sees. Take time to focus on activities that are enjoyable at home, even little things which are pleasurable. Maybe just looking out of the window, but obviously it depends on the person's circumstances. Tidying something or doing outstanding chores, maybe something you wanted to do for a long time, never quite managed to do it. Try to do that, put that as a plan. And those kind of things give you a sense of achievement. You have done something, you have achieved something positive, and that might help also to distract your mind from all those doom and gloom. Keeping physically active and keeping an eye on the diet is very, very important. I know we have indulged in cooking, which is good some way because it brings some pleasure, and also the families coming together provide support to each other. But at the same time, it is very important that we keeping physically active and keeping a diet, because otherwise we are just inviting problems further down. Sometimes simple relaxation techniques like breathing exercises might help people. This is widely available. Maybe people can get from YouTube and just practice themselves. Or the healthcare professionals might help them to learn techniques which they can practice by themselves. And avoiding too much tea, coffee, and alcohol, which we have said, that obviously doesn't help. Now, what have we learned from it so far? As we have said, that still it is an unfolding story. We are still learning about COVID. We still don't know how long this is going to go like this. I think the learning and translating it needs both at a personal and a policy level. So at a policy level, what has been done quite effectively in England is helping particularly vulnerable elderly with practical help like shopping, food, medicine, domestic help, personal care, and financial support. It's not in the UK. We know that at various levels, this has happened all over the world. And I'm quite impressed some of the initiatives that has happened in India as well, not only just by the government, but also by local initiative, by voluntary sector. So it's all our responsibility. We need to put together both the government and non-government resources and try to sort of help particularly elderly. And then we need to focus on specifically vulnerable group, like frail elderly with multimorbidity, elderly with no children or close relatives. That means, elderly who might be living alone and also have no family support, even the wider family support, elderly with dementia and or other mental health problems, and particularly the care home populations. So these are within the elderly, these are specifically vulnerable group. And sometimes our resources and our policies should be targeted towards that. I think maintaining clinical care and support with the help of telemedicine, and where necessary, maybe face-to-face or direct contact as much as possible. What we have learned in many places where we have seen that the care, sort of clinical care, has completely shut down. People have been pushed from pillar to post, and that doesn't help. And sometimes people are terrified to seek help. And what we are doing is actually just building up problems which are underlying. And this will also have a huge impact on the healthcare once people will start accessing it. So keeping that going as much as possible, despite of the pandemic and the restraints within the safety parameters, I think is very important. Obviously, there is a downside to it, which has happened in the UK, because obviously the government wanted to protect medical staff, not only doctors, but all healthcare staff. So that's why the government had no choice but to stop or reduce non-urgent contacts. And that's sometimes you have to do, because otherwise, if most of your healthcare staff get ill, then who is going to provide the care? And we have seen, despite all those measures, how many healthcare professionals have lost their lives or become very ill across the globe. Focus on personal resilience. We have already sort of touched upon a few points which people can learn and try to practice just to build up their own ability to go through this very turbulent time. Resilience is our inner ability to deal with adversities and stress. And definitely, elderly, they have seen a lot, and maybe that could be focused on. If you have been through a lot of difficulties in your life, can you actually try to pull yourself together? And some of the studies are indicating actually in some elements, elderly may be coping better with the younger population because of their inner resilience. And because of what I've touched upon, the issue about rationing of care, ceiling of care, I think we already have robust legislation about advanced directive end-of-life care, but that needs to be revisited. We need to prepare ourselves. The pandemic is not gone. In the Western world, countries like India, Brazil, USA are still at the middle of the storm. Europe kind of recovered a bit, but we can still see it creeping back, and a lot of anxiety that it's going to come back again with fury over the winter months. So we are not out of the eye of the storm. We need to sort of consolidate what we have learned so far, try to bring that in our policy and practice as much as possible, and hope for the best. Thank you very much for listening.
Thank you, Dr. Sujay. Thank you very much. It was excellent presentation, which indeed was yeah, sorry, I think I was muted. Thank you very much. It was excellent. Now, as I said, we will if there's any questions, we'll be putting it up in a chat in the chat box, and Professor Derek will be arranging to have this answered if you with the speakers. That was about wellness in the elderly, and I think this is so important. Now, the next speaker is the lead Professor Shabir Amanullah, who actually is the lead presenter who organized or who planned this program today. So I'm very delighted, and he's part of the committee and part of the faculty of the UNESCO Chair in Bioethics Education Department. Now, Professor Shabir Amanullah is the head of psychiatry at Woodstock in London, Ontario, and he's with the two universities, the University of Western Ontario and also with Dalhousie, and working with the psychogeriatric area. But while he works there, he has a much broader and a deeper areas of health, psychological health, physical health, and so forth. And today, I'm delighted that Professor Shabir is going to present to us the topic, pandemics and mankind. What to expect post-COVID, the 19 that we are facing in 2020. Over to you, Shabir, and thank you for your contribution.
Thanks, Russell. Thank you very much. You can hear me clearly?
Yes, I can hear you.
Perfect. So in the last roughly 3.5 to 4 months, we've done well over 50 plus webinars to different groups and different audiences. And one of the things that keeps coming through as a theme over and over again is there's a lot of sadness, there's a lot of worry about what really is going to happen post-COVID, or if COVID ever will get over and things like that. It's quite easy to feel despondent, dejected, and many people actually don't really have depression per se, but there's a new crop of worried well people coming up, especially amongst the teenagers. And it's very interesting to see how psychopathology has evolved from being the conventional DSM-5 classification to actually having these very subsyndromal pictures, which we do struggle to kind of categorize because we don't have data. And like Sujay quite rightly mentioned, there are some things that we may think are more unique to the elderly, which may not be true. Maybe they are more resilient. Prabha spoke about the postpartum, the peripartum. There's a lot of issues with maternal mental health that we weren't even aware of. So what this lecture was meant to do is meant to take us from history to philosophy, to look at what it is that we can actually do so that the pandemic does not take a toll on each one and every one of us, both mentally, physically, or even spiritually. So it's just meant to give a global perspective in terms of how things can evolve and how we can manage ourselves, both individually, our families, and the community.
उसका ईयर प्लग सानवी कला दो पे काला रंग का है.
I think somebody's microphone is not on mute. So the pandemic we're currently facing, it really isn't unique in Sorry, Derek had muted me.
Sorry.
Yeah, thank you. So the pandemic that we're seeing, it's not really unique in terms of an illness that's affecting mankind. It's unique in terms of the context and the fact that we're in this century, the 21st century, and how it's impacting us. So if you go back in time and you look at how people have struggled during pandemics where there was no water, many people didn't have food, and many people still don't have food. Many people still don't have access to water. They don't have shelters. So when I talk about shelter, I'm talking about safe places where you can get away from the rain, get away from the sun. There are many people who don't have that. And then you have lack of medicines. Now, the problem with all this is we expect people who have homes to be safe. But like Prabha said, there's a lot of domestic violence. And if there's domestic violence, it's not domestic violence the way we conceptualize it to be, that it's the husband beating the wife or being abusive to the wife. It can be to the family as a whole. It can be children who are being abused. It can be relatives. And if it's a joint family, extended family, there are a lot of people who are going to be abused. We also know that during the pandemics in the past, people were scapegoated. Specific groups would be targeted and said, you're practicing witchcraft and you're the ones who are spreading disease. Nothing much has changed from then, except that now we have control over information and dissemination of information, but yet we don't have control that we give proper information. So in terms of things and how it evolved over the centuries, we still have those viruses and bacteria that are still going to wreak havoc. But the things we have control over, somehow we are not able to get a whole rein on them. Many, many more people obviously succumbed to the disease itself. Now, if you look at the evolution of plagues, and this is by no means an exhaustive list, this is the ones that we kind of have some kind of a timeline on. We have some kind of records that we can prove that show that, yes, this happened. But if you look at it, if you look at how the death toll has evolved, during the Black Death, the bubonic plague, if you look at it between 1346 to 1353, and you look at the duration, a 7-year span, it's actually pretty phenomenal to see the number of people dying. 200 million people died in the span of 7 years. But then what happened after that? It's almost as if every plague, every virus, every pandemic has some kind of a finite nature to it. So when you talk about the light at the end of the tunnel, I'm not saying that we have a vaccine coming up tomorrow. There's this funny video going on about the Russians coming up with a vaccine for the pandemic, for COVID, and they say it's the next best thing after vodka coming out. There's a lot of humor coming in these days coming as well. But it's important to recognize that there are people who are very optimistic. There are people who have a funny take on everything in life. So the fact is, like Sujoy said, if you choose to tune in to the negativity, you're going to feel miserable. So what is it that we should learn from mankind? What is it that has happened over the years? If you look at the HIV pandemic that we had, at one point in time, during its peak, 36 million people died. Now, when we look at HIV, we kind of know how it spreads. We know what things to do to prevent its spread. We know how to protect ourselves. But at that point in time, it was scary. We really had no idea as to what was going on at that point in time. Absolutely no idea. So now when we look at it and we see mothers being told, you cannot come to our home, I'm vulnerable, it actually should make us go back in time and look at things that happened and be far more calm in our approach than being dramatic. So what can we do? Well, the first is we need to think of the plagues that we have control over. What is it that we have control over? Well, we have put satellites in space right now. I can talk to you from thousands of miles away in the comfort of my living room, and you probably can't even see that maybe I'm wearing my pajamas. But I can do that, right? I would never be able to do this years ago. Technology has made that possible. But what is it that technology has also done? Technology, unfortunately, has not been able to control the hate plague. We see so many negative messages coming out. It's astounding. I have seen messages targeting specific sexes, those who belong to the LGBT community, those who have disabilities, those who belong to specific religions, those who belong to castes, language. It's incredible. As just as much as you have the positivity, you have phenomenal levels of negativity. So when we talk about the plague and the virus has probably given us a common enemy, a common theme to attack. But we still haven't challenged the hate plague. What does it tell us? It basically tells us that as a community, we still have a long way to go. We still have a lot of work to do, but we still remain complacent. So just as much as we need to tackle one side of it, we need to be aware of the negative impact it's having on our future generations. And you will see as the lecture goes on what I'm talking about. Now, the impact of COVID-19 is only beginning to be felt. So when you look at us as a human race and the cost is going to be enormous. We know that GDPs of countries have come down by 1.5%, 3%, which is pretty phenomenal. But this GDP does not take into account the suffering of the laborer, the farmer, the rickshaw driver. These indices measure the stock exchange, productivity within industries. So are we really serving the community who is the most vulnerable? Forget the community Prabha spoke about, the pregnant population. Forget the population that Sujay spoke about in terms of the elderly. I'm talking about the people who have always been vulnerable. What have we done for them even pre-pandemic? What have we done? We really haven't done very much. And yet we wax eloquent about how humanity has progressed. How can humanity progress if one group of people are still suffering? These are fundamental questions we need to ask ourselves before laying it out on the COVID and saying COVID has destroyed everything or is making it much more difficult. Now, what about in terms of the fake news generation? There was a news that came out of Iran. This is going back probably a few months at the beginning of the plague, where people were told that alcohol prevents the spread of COVID. And there was this news, I couldn't confirm it. There was this news that many people died of alcohol intoxication. Now, it beggars disbelief that someone would actually do something and write something and somebody else is suffering because of it. So we all have a duty to basically regulate information going from our hands. So before we click the forward button, it's important for us to make sure we know what we're doing. What has been the impact on families and communities? Now, when Prabha was talking about the difficulties within the context of families and domestic violence, we know the rates have gone up very high. It's not just in India, it's not in Sri Lanka, it's not in Bangladesh, Pakistan. It is actually happening even in Canada. We see this happening all the time. And now there are ads on television which tell women, if you're being abused and you can't get out of your home, there is a specific hand sign you can show to tell the person you're communicating with that you're being abused and they can call the police. This is the 21st century. This is when we talk about equality and, you know, women have equal rights. Where is the equal right? If someone is still being abused, what have we achieved? Forget COVID. I'm talking of even pre-pandemic. The pandemic just made it worse. So if you look at it, we have the opportunity now to actually either address it as being domestic violence or we promote domestic bonding. So with this, the cooking that Sujay spoke about, there are lots of different things that individuals can do to promote domestic bonding. We really need to look at it as this or that, because sometimes it's hard for us to see the gray area when we feel like we are stuck. Physical violence, is it truly an alternative to activities you can actually indulge in, which would actually bond you better? Nothing stops you from going for a walk. Nobody's preventing you from going for a walk. You can even do your treadmill. If you don't want to do it at home, you can do yoga at home. Nobody's stopping you from doing it. But the fact that we often think that there's only one particular channel is often a fallacy. And it's being able to reach out to the most vulnerable people and populations to say, look, if there is anger, if things are building up, proximity is an issue, you can always make the proximity much more productive. Financial ruin versus financial success. The number of industries that have sprouted after the COVID-19 is incredible. You look at the number of people doing deliveries, not deliveries that Prabha spoke about, but package deliveries, Amazon. Look at other people delivering food. Look at the industries that have expanded in terms of them coming and doing your garden for you because you don't want to go out and do the gardening at this point in time. You want to cut down exposure. There are people who are doing that here. They come, they have all the mask on, they do everything that's supposed to be done, but their workload has gone up because many people are hesitant to go out of their homes. So it is not just difficulties that we're seeing opportunities. So those who had financial ruin, there's lots of financial successes. What does it tell you? It tells you we need to change the way we think. What about academic stagnation? I know many academics are saying I can't do randomized controlled trials, but if you look at the number of papers that have come up in the last 3 to 4 months, it's incredible. Many of them have not been vetted very well because we don't have any gold standard to measure it to, but there's a lot of research papers coming out. Many people are sitting at home and churning out one paper after another. The good thing, we have a lot of people connecting across the globe because it's no longer going to be restricted by geography. What about junk food? This has been one of the concerns. And if you look, there's a beautiful WhatsApp message. It's a bit humorous. It talks about how after the pandemic, you're probably going to end up as a hunk because you're exercising, or you're going to end up as a chunk. It's this big ball of lard because all you're doing is eating and not exercising. So we have the opportunity. Are you going to overindulge in food? Are you going to create cooking as a medium by which you can increase domestic bonding? Are we going to have diets that are more controlled diets, have a sattvic diet, or have switched to a good balance between meat and vegetables? Are we going to do that? Because this is an opportunity to do that. We also need to look at whether we want to forward messages that fuel disharmony versus we want to create harmony across the globe. We have that choice. We really have the choice now. Now, I think it's also important for us to look at politics of hate versus politics of humanity. There is no in between, because you either choose to do what's right or you choose to do what's wrong. We all have a radar, a compass within ourselves that tell us what's right and what's wrong. What about resilience? So Sujoy very briefly spoke about resilience in the elderly and how they may actually be doing better. The concern I have is with the youth today, and many actually not having the bonding you have as a teenager, because that's the time when you spend more time with your friends than you do with your parents. Now you're stuck at home and you really don't know what to talk to your parents about because there's stuff that you speak only to your friends about. Now, how do we use technology to enhance resilience? Well, this is very challenging, and this is where we really need to be investing a lot of our time and money in, because we really need to be careful about the youth. The youth do not have a safe space because the internet is flooded with people who crack into your web programs. And we know now that there's a lot of concerns with people being given information that's not true. So if you look at a video that was circulating roughly about 2.5 months ago, it was about an American couple and how their 4.5-year-old daughter was exposed to very specific targeted advertising, which was highly inappropriate. And every time they would take the computer, it somehow was able to profile them very quickly through AI, and that message was not given to them. It was only to the child. So we need to be cognizant of it. We can't be ignorant. We need to know what kind of safe space children have and probably create that platform. We also know that new alliances are being formed. We knew new frontiers in science and technology are being conquered. We need to be part of it. We need to be part of what's positive, what's true, and what's evidence-based. So how do we make sense of all this? It's quite simple. Man needs to take control over what we have control over. We have control over our behavior. If I so choose to pick this cup and have my tea, I have a choice. I have a choice on my cell phone to click the forward button versus deleting it or sending a message to the person who sent me the message saying, please don't send me messages like this again. I have a choice to do that. There's been this big thing about, circulate pornography versus hate messages. Pornography is hate message against women. The amount of sexual violence against women I have seen after coming to Canada because of pornography is very high. It's not an excuse. Like I said, we have a choice. Now, what do we need to do as a community? We have to stop doing the you, me, we thing. It's us. If I have the virus, I need to wear the mask. If I don't have the virus, I still need to wear the mask because I don't know if I have it or not. I can test negative 10 times. And we know now that sometimes you test negative throughout and people have died of COVID. So we have a responsibility here. So making sense of all this is you taking responsibility for what you have control over. What else do we need to do? We need to really look at suffering. When people are suffering down the road, we have a duty to be able to help them. We have a duty to be able to provide for them. There is really no excuse for us not to be doing that. Moving forward, one of the best things that has come out of COVID has been that I have been able to connect with some academics who I never knew about. And I can honestly tell you, they are absolutely brilliant. I was telling Russell he called me a few nights ago and we were having a discussion about, knowledge transfer and how we manage human capital, how we manage people. And it was amazing to look at what he spoke about in terms of how there is a phenomena called moral injury. It was very interesting because I didn't know this term. But it was really an eye-opener in terms of things that are evolving over years, because I would have wanted to go to Harvard and pick up the Harvard Business Review and look at what they're talking about. Why would I want to listen to anybody else? I connected with a guy from IIT Kharagpur who does work on cannabinoids. He's an engineer. And this guy was absolutely brilliant. I took great pleasure in that in 2007, I was one of the first using synthetic cannabinoids in dementia. And I started talking to this guy and I realized, oh my God, there's so much more I need to learn. If it wasn't for COVID, I would not have connected with this guy. So ideas can come from anywhere in the world now, but we should be willing to listen. The bias, the prejudice we had, saying that some countries do not have the ability to provide that technology, has gone. But we have a duty to provide the platform. There is no excuse anymore to say, I can't look at the sunset because I have to go for work. You do. So you have to be aware of your mental health. You have to be aware of your actions. But more importantly, you have to take responsibility for it. Being grateful. There's a lot of evidence to show that giving is far better than taking. But being grateful is actually a form of therapy now. Being grateful has its own incredibly beneficial actions. So how do we maximize human capital? What is human capital? I'm going to play a video. And I want you to listen to absolutely brilliant video by.
Ladies and gentlemen, I'm indeed delighted to be with the honorable members of the European Parliament on the occasion of the Golden Jubilee year of the European Union. I am reminded of the dream of an Indian poet, Kaniyan Pungundranar, who articulated in 3,000 years back in Tamil classic Pranam. He says, Yadum Ure Yavarum Keli, which means I am a world citizen. Every citizen is my own kith and kin, he said 3,000 years back. As we say in India, where there is righteousness in the heart, where there is righteousness in the heart, there is beauty in the character. When there is beauty in the character, there is harmony in the home. When there is harmony in the home, there is harmony, there is an order in the nation. When there is order in the nation, there is peace in the world.
Now, I believe you could all hear that.
Yes, yes.
It's profound.
Yes, we could.
And we keep forgetting how important it is for each of us to believe in the concept of being righteous. We have a choice. It's not an excuse anymore. But what we have to do now, it forces us as a family to be together. COVID has actually brought many families together. This is one family I'm talking about. I have no idea about the participants from Sri Lanka, but we're here together sharing a common platform. And one of the themes in the bioethics curriculum that is rolled out from the bioethics, UNESCO bioethics unit in Haifa is the whole notion of solidarity. We are in solidarity when we talk about ethics. We are also in solidarity when we talk about righteousness. There really isn't an excuse anymore for us to bury our heads in the sand. Now, one of the things I wanted to bring in within the context of what Dr. Abdul Khan spoke about, the previous deceased president of India, we need to realize that the first thing we should be doing is not harming anybody. So when I said don't forward the message, it's because I'm saying don't hurt anybody. The second thing is whatever we do that inculcates righteousness, positiveness, and resilience starts at home. Create a purpose for people in life, purpose for you and your family. Develop work ethics. There's this thing about making a quick buck and cheating people. And you see that all the time. You have these movies that have been made about Hollywood heroes who made a lot of money very quickly. You know, there's another story by a guy called Lee Atwater. If you get a chance to read that book, read it. It's a guy who helped the presidential campaign of one of the candidates and completely ripped apart Dukakis's campaign. This guy was 30. He had made it. He was wealthy. He was powerful. He knew everybody in Washington, big guy. But he was diagnosed with brain cancer. And he said, the only thing I want to do now is to ask forgiveness from everybody I hurt. It's a pretty profound statement because as human beings, although our existence is collective, our birth and our death will be individual. We owe it to ourselves to be responsible. So what can we do? Inculcate the quality of being kind. Kindness is an incredible virtue. There is so much of suffering in the world. We owe it to ourselves, to our spouses, our family, and the world we live in. Learn how to cope with failure. This has been said many times with management gurus. Learn how to cope with failure, you will cope with success. Maybe people ask, why do I need to cope with success? Because people who have achieved success are the ones who often suffer the most. What about being grateful? I mentioned this a few slides ago. Being grateful is a stress buster. Human capital management begins at home. And I'm going to end my talk with a very, very simple saying by the Prophet, peace be upon him. Kindness is a mark of faith. Whoever is not kind has no faith. Thank you.
Thank you. I hope I'm all right. Yeah. Thank you, Shabib, Dr. Professor Shabib, for illuminating presentation that really brought purpose into all what we are doing, and certainly brought avenues to find meaning in this perceived or to be meaningless world that we are trying to grapple with, that COVID has brought in. This is another way of thinking, another way of positivity. But very importantly, I do a talk. In fact, a few weeks ago we were doing this on gratitude and how important this positive emotion. Two very important positive emotions: gratitude. So we talk of the science of gratitude, and the other is compassion. And these two positive emotions, although it's been there from every ancient book or scripture, I'm delighted that universities, major universities, are now using much resources into studying gratitude. And I was looking at the work done at Miami, UCLA, on radical gratitude and its ability to cope. And they show with someone with a brain tumor, the use of radical gratitude, and the other very important areas. So I thank you so much for giving us this opportunity to reflect amidst this pandemic and so forth. And I totally agree that for us, the UNESCO team, which all of you are part of, this 20 webinars has brought the world together in solidarity, which is Article 13 of the Universal Declaration on Bioethics and Human Rights. I see with us here my colleagues from all over the world, I see Major General Zin from Malaysia, our Haris Chandra, from North America to South America to East Africa, and this solidarity, and I think what you explained here is indeed very, very thoughtful and meaningful, and I'm sure most of the participants will appreciate that. And now, of course, I'm going to try and bring to you the last part of this. When we talked of human capital, I'm just trying to get this. The final one, as you all know, the issue about, we're all talking and we're all discussing this very important aspect. In fact, we've had one of the issues, this is about the mental health and of the healthcare workforce. The workforce that is there showing compassion, taking care. And we had a couple of webinars, and one of the areas was the ethical dilemma that we face with the workforce. Is it appropriate for the healthcare workforce to take care of their patients with COVID, knowing well that they might it might be injurious and they might lose their life? What about when they had a scarcity of PPEs and other equipment, ventilators and so forth? This was in one of our webinars. This was one of the areas. The World President of the World Medical Association was there, Secretary General, and they were looking at how do we deal with this dilemma. What about many countries calling back retired healthcare doctors and nurses and so forth, knowing well that they are the vulnerable, but being willing to bring them in and to go on to the front line. Or on the other side, we had another discussion about medical students or even other healthcare students in some countries are being pushed through to become doctors to go straight into the front line. So these are some of the epidemic, or at least, sorry, the ethical dilemmas that this pandemic has brought. And particularly when we talk about human capital management, I'm talking here, I am the head of the education department of the UNESCO chair in bioethics, and also the head of Asia Pacific division, the largest division in the UNESCO. But we are also, we're from, and in fact, Shabir and many of you here are fellows or members of the International Institute of Organizational Psychological Medicine. That is the branch of psychological medicine that actually looks at the workforce. And productivity is the outcome in organizational psychological medicine. And this, I'm going to finish, bring you to the other part. We spoke about the maternal. We spoke about the elderly. And then Shabir beautifully brought out mankind, the human requirements. And then we come back now to those, to the workforce that's showing compassion, that is willing to go out and may do that, take that extra step to save, to reduce suffering. And what are we talking about in this, with them? So we were looking at what we've learned in the current pandemic. So what we've seen is the emergence of this novel coronavirus SARS-CoV-2 and the resulting global pandemic. These have a significantly taxed the capabilities of healthcare systems around the globe. Yet the long-term psychological impact of COVID-19 pandemic on the frontline healthcare workers has yet to be fully understood. Every day we are learning more. In Australia, we have over 1,000 at this moment who are healthcare, who are at the moment positive with the virus, but a lot more are impacted from the psychological sequelae of not only the positive, but also dealing with the whole area of, and taking a hold of treating. So attention to staff mental health and well-being is another crucial aspect of any crisis management. Now, infectious disease outbreaks poses a unique challenge to healthcare workers compared to all the other disasters. We have disaster planning, disaster preparation, but disasters where infectious disease outbreaks are unique because they arise from both the nature of the disease and from the need to protect themselves from the infection with measures such as quarantine and the use of personal protective equipment. Undesirable effects of psychological well-being among frontline healthcare workers have been well documented already. And this includes the risk of depression, anxiety, substance misuse, and indeed insomnia and sleep disturbances. If we take the current pandemic, I don't need to go into detail, but here are some evidence from the surveys done with the healthcare workforce in Italy, in China, in India. All of them quite clearly substantiate significant psychological issues from PTSD, depression, anxiety, insomnia, and importantly, you will see stress coming up, perceived stress, perceived stress, perceived stress. And of course, from the Indian perspective that I reviewed, there is perceived stress, but there's also perceived stigma, which is also has its own impact on stress. Here's to give the graph coming up with some of the common areas. This is from a Chinese study, but we see significantly distress as in this in the last 6 months from what surveys are being done. We see that depression, anxiety, and insomnia, but distress seems to be stress and distress seems to be featuring high. Now, what we've learned and what we've seen in more recently, as you could see from the several publications, all in the last few months, is the experience of moral injury in the frontline health workers. Moral injury in times of COVID-19. Moral injury in Chinese health professionals during the pandemic. Moral injuries among healthcare providers, and limiting the moral injury in healthcare providers. These seem to be a new area, an area that is overwhelmingly being seen or experienced by the frontline healthcare workforce in this pandemic. I want you to now imagine being a healthcare provider. You're required to triage a COVID-19 patients, and you're inside this crowded emergency room deciding which of the two patients will get your emergency room's only remaining ventilator. Although you understand the situation requires you to give the ventilator to the person with the higher odds of survival. Yet you are not trained to make this kind of decisions. You always had resources to equally treat all patients as ethically required, as morally required. But in this scenario, both patients die now, despite one having been put on a ventilator. Imagine yourself in this situation. And you go on now to wonder whether you made a wrong decision. Could the other patient have survived with a ventilator? You're racked with guilt, replaying this scenario over and over, analyzing how different choices might have created different outcomes. Your distress becomes overwhelming. So you bury yourself in work, but the pain that follows goes along with you home. You avoid genuine conversation with your family and peers because you're distracting yourself at the expense of routines that were once meaningful. You tell yourself that you followed protocol. You did your best that you could. and yet you still feel like you violated your own moral values. This is where moral distress that we now are seeing and hearing that our diligent workforce are having to put up with, having to deal with, having to face with, having to live with. This scenario is precisely the context in which moral injury may develop. Very little is in fact, this is probably the first time we are hearing an understanding about moral injury in the non-military populations. And our COVID-19 pandemic has now made it clear that moral injury's relevance now extends beyond the battlefield. It's natural that in response to these potentially morally injurious events, we call it potentially morally injurious events, people experience moral emotions like guilt, shame, disgust, anger, and contempt, as well as their cognitions relating to not only blaming themselves, but even blaming others at times. Moral injury occurs when these painful moral emotions and cognitions, what sometimes we try to avoid or suppress it. And this, of course, results in greater suffering that ultimately negatively impacts the person's ability to function effectively. And what we see then is social, psychological, and even spiritual suffering often present with this moral injury, as difficulties in meaningfully engaging in valued areas of life that otherwise which would have been so important and meaningful, such as relationships, spirituality, employment, and indeed self-care. Now, we talk about this moral distress and moral injury. How do they relate to each other? We see moral injury, distress, and moral injury may appear to be very similar, since both relate to moral suffering. However, from what evidence we have now, what appears to mainly distinguish moral injury from moral distress is that moral injury seems to be associated to death-related incidents. On the other hand, moral distress seems to refer to moral dilemmas or else moral disequilibrium experienced by multiple mundane incidents that our frontline healthcare professionals may frequently experience in their very line of duty. And to this end, moral injury, for instance, may be experienced with intense feelings of guilt, shame, and frustration that a healthcare worker may experience, often to death-related incidents, as we see in this case that I just asked you to imagine yourself. On the other hand, healthcare workers may experience multiple incidents that may cause moral distress, but over time, guilt, shame, and other feelings accumulate due to multiple mundane, morally distressed causing incidents in their line of duty. So little by little, these multiply, and moral distress and moral injury are cumulatively intertwined, and eventually they lead towards traumatization. And of course, when we talk about that, we now look at moral distress and stress. You will note in all those studies, we've been hearing about stress, distress as, in fact, predominantly higher than most of the other psychological issues that the psychopathology that we've been following in the surveys. Multiple experiences of moral distress results in what is called moral residue, or a buildup of unresolved conflicts within the clinicians. And there is such a thing called tolerable stress. There is positive stress, there is tolerable stress, and then we have toxic stress. Now, tolerable stress, this leads to, of course, tolerable stress. And this is the stress response are more severe, frequent, and sustained. The body responds to a greater degree, and these biochemical responses have the potential to, in fact, negatively affect brain architecture. Now we talk about chronic moral distress, moral injury, and how that is related to toxic stress. So moral distress and moral injury are intertwined. The continuous experience of multiple critical incidents leads to the experience of moral distress, moral injury, and thereby chronic toxic stress. Toxic stress results in a prolonged activation of the stress response, with the failure of the body to adequately recover fully before the next activation takes place. And what does this do? It affects the neuroendocrine immune network, and the response then leads to a prolonged abnormal cortisol response. And the result of that is immune dysregulation and a persistent inflammatory state. So we see now the evidence that this moral distress, moral injury, leading ultimately to this toxic stress response. And this is now believed to play a role in the pathophysiology, not only of depressive disorders, but behavioral dysregulation, post-traumatic stress disorder, and indeed psychosis. Now, that's an aspect there, but we also see in this type of pandemic work, the frontline have a challenge often to their morals because of competing obligations. Change practices that we all know is taking place in the healthcare when we are dealing with the pandemic. And this, of course, inevitably results in tensions. Some of them are the individual's clinical ethics versus public health ethics. The best medical practice versus working with resource scarcity. Expert practice versus practicing at the edge or at times beyond one's competencies because of the because of the pandemic, because of the situation, because of the scarcity, because of the surge of the patient load and so forth. These tensions generate moral dilemmas. And with a high likelihood, these moral dilemmas have the likelihood of causing moral distress. And moral distress occurs when external and internal constraints preclude the performance of an ethically appropriate choice or action, which is generally what the workforce, the healthcare workforce, are used to, ethically appropriate choice or action. And multiple experiences of moral distress can result in moral residue or what we call a buildup of unresolved conflicts within the clinician. And what does that do? That makes future scenarios that create moral distress even less tolerable. So we are seeing this aspect of psychological or mental health issues that are being revealed here. In the past, it would have been, this was known only in the battlefield, and on return from the battlefield, we saw moral injury. But in the current pandemic, we are beginning to see the link of moral injury, moral distress, and chronic toxic stress. Now, Dr. Shabir and Dr. Sujay have talked about the need for cultivating moral resilience. We see that the American Nursing Association, many of the other organizations are now bringing forth the importance of cultivating moral resilience. And some of the areas that they've been discussing and bringing us, trying to promote is fostering self-awareness, developing self-regulatory capacities, importantly develop ethical competence, speaking up with clarity and confidence, and finding meaning in the midst of despair, something that Dr. Shabir was bringing in his advice there, engaging with others, participating in transformational learning, and importantly, contributing to a culture of ethical practice. These seem to be avenues, areas that promote the cultivation of moral resilience. So that's where we are. And then when we look at some of this managing, we are in the beginning of this. And so some of the thoughts are about treatment programs that should promote early intervention and developing tailored interventions for different populations. And some of the existing treatments for moral injury, moral distress, such as acceptance and commitment therapy for moral injury, given there, the spiritually augmented cognitive behavior therapy, adaptive disclosure, all these, from what we see, provide promising foundations for these such tailored approaches to try and work with moral distress and moral injury. So I stop with this and will take you back to look at what today we've been able to bring to you from the distinguished speakers along with me who spread from the northern hemisphere, from on top of the world in Ontario to myself underneath.
I think Dr. Russell maybe had a power failure, so possibly we'll just wait for him to get back online. My heartfelt gratitude and appreciation to all the presenters. I think that has been the uniform message that is coming through. So thank you, Dr. Prabha, Dr. Sujoy, Dr. Shabir, and of course, Dr. Russell. There are a lot of questions and issues, and I think most of them, of course, have been covered. So gratitude for that. Dr. Sujoy, I think you already mentioned about the fact of reaching the ceiling and the other issues. But the biggest problem during the pandemic has been the low resource availability and the high pressure. And that again leads to moral distress from all sides, because even the administrators are torn where they have to make hard decisions. The healthcare workers have to face the violence, the doctors, the nurses. So, especially for the younger generation who are not that experienced or who don't know how to handle, what is some of the advice that you can give, or some of the issues that would make it easier for them to handle this pressure situation? Dr. Sujoy, please. You can unmute yourself, please.
I can't because the host has muted me.
Yes, you can now, sir.
Thank you.
Yeah.
Thanks, Dr. D'Souza. Well, as I said, I mean, if we go back to medical ethics to help us to make the decision, as I put one of the comments that there are sort of three key elements. One is autonomy, one is beneficence and non-maleficence, and the justice. And we are here talking more about justice. Obviously, the autonomy part is important because if people have advance directive, if people could say what care they may or may not want in certain circumstances like advance directive and all, that helps decision making. But as we know, that's even in Western countries where the legislations are pretty well developed, actually the take up of advance directive is still very low. So it's not always very helpful. In terms of justice, I think the key issue about justice is who gets what, and that's a very difficult question when particularly the need is very high and the resource is very low. I think some difficult decisions has to be made, and I don't think it can be made by an individual. I think what it is, at a unit level, there has to be a joint decision. So like we, as I say, a hospital make that decision, and that should reflect on the decision made by the healthcare sort of in the healthcare overarching sort of committees or departments. And this is not just a clinical decision. I think it is also a political, cultural, and national decision. And we have to be transparent and open, saying, look, this is our situation, this is what we have, and then we have to prioritize on certain criteria. I think the problem happens when we are not open and honest about it, and also when it is not used equitably. I know somebody, so I get into a ventilator. Somebody else doesn't know with the same problem, but they can't get it. And that's where the problem comes in. I think, it is very difficult to say, well, this decision has to be made because the situation changes, but we have to have some broader agreed principle. And we have to accept that, some difficult decisions have to be made by the professionals there. The other issue is also preparation. Obviously, COVID has got many countries, even the well-developed countries, Western countries, absolutely wrong-footed. They couldn't really understand that what is coming towards them. But having said that, even within that, you could see that the outcome has been quite different between countries. Now, part of it may be because the virus has affected different countries differently, but part of it is also how the politicians reacted, what their value system was, and what kind of preparation they made. And I think that's another learning. We have to think that this is not the last one. I mean, we even don't know how long this will last. And I'm sure there will be similar challenges in future. So I think that preparation and that honesty, that how much resource we are going to put in our people's health. So health and education, are they going to take priority over other things? That's a big question over coming times.
Yes, sir, you're absolutely right, and thank you for that insight. And I hope that helps the others. I know it's a challenge. I'll come to you, Dr. Prabha. There's been a lot of talk about once there is the demise of a patient. What is different is that you don't really get to meet the patient in the final hours. In certain cases, you don't even get a chance to see the person. It's wrapped up in many layers of plastic and protection. We are aware of those situations. So there is a lot of moral distress, tragedy, not only in the immediate family, but even among the healthcare workers, because I've seen it happen in our own institution where you have the body that is lying there, you can't really shift it around. Sometimes it happens late night. You can't shift it to the mortuary. You have to wait for the morning hours. How do we deal with such a situation, both for the families as well as the healthcare workers themselves? Some tips or suggestions that you could.
My apologies. I seem to have lost for a little while.
Yes, we lost you. Welcome
Yeah,
back, sir.
Yeah, my apologies for that to everyone. Yeah.
Yes, Dr. Prabha.
Yeah, thanks, Derek, for that observation. In fact, it was just the other day that we had a case conference for young students on somebody who had family member who had died due to COVID, and the person presented to us with a grief reaction because of this very reason. One, they perceived it as a stigmatized death because they couldn't really talk about it very much. And second, like you rightly said, that the rituals and the mourning that is conventionally present, which helps us grieve, which helps us accept a loss, is completely taken away. And so I think it is. I don't think I have any sort of definite answers about what we need to do because it's completely new. But one of the things that I think health systems can do is giving proper information much upfront. So many times people don't know that this is what's going to happen, and that comes as a complete shock to them. So telling them upfront, that this is what it is going to be like. These are the kind of restrictions we have. We thought we'd let you know. I think just some empathic discussion about how hard it must be for you, and we recognize it, but certain things have to be done because of infection control. So I think just having somebody who will take you through that initial acute grief is very important. And health professionals, I think what we do is, because we think of death as a failure, and many of these things which are happening are equally distressing to us. So we find it very hard to address these things with the families of the patients who's passed away. So what I would recommend is that one, being very honest, empathic, and authentic, and saying that this is very hard for you. We recognize that. And is there anything else we can do to preserve this memory? Or is there some sort of reminiscence that we can do, which doesn't necessarily involve handling the body, but something else that can be done to make you feel better? So I think like we do with other deaths like HIV or other stigmatized deaths or other infectious diseases, there needs to be this dialogue. And physicians particularly, because we are not going to be around at that point. It's going to be physicians. And physicians are not known conventionally to accept death as something which they can talk about. So I think this is a good opportunity to teach our fellow physicians about how to talk about death and dying, how to talk about grief, what you can expect, not to perceive people who are very upset and angry as difficult families, but to actually acknowledge their distress and find alternate ways of celebrating a person's life or mourning that loss, which does not involve the actual touch. So those would be my recommendations.
Thank you. Thank you, ma'am, for that. I think you summed it up pretty well. And like Dr. Shabir said, there are so many things we are still learning. And the more we share and tell everyone, that whole idea of solidarity and empathy, I think, always trumps. Once the patient or the family realizes that you are empathetic, you understand their situation, I think that makes our job much easier. It's always when that empathy is not felt or perceived from the other end, that is where the problems start. It's not really those concepts of being negligent or the doctor didn't talk to me properly. It's always empathy that comes out. Dr. Russell.
Sorry, what did you ask me something, Derek?
Yes. We were talking about, we were talking about the tragedy that is felt not only in the family, but also among the healthcare workers when a patient dies in the COVID ward, and the fact that you don't get a chance to even say a proper goodbye. The body is handed wrapped in many layers of plastic. You don't even get to see the person, and the normal rights, everything is restricted. So that adds to the distress and to the trauma on both sides, the immediate family as well as the healthcare workers. So what was your take on that, Dr.
Well, I think what Dr. Prabha said, I mean, these are the issues. We were just listening. What we're having in Melbourne, you know, we're having this couple of nurses have come up and had this briefing on TV talking about how they had to hold the hand of a patient. No family member was there. The patient knew they were going, and they had to be the only person there, and the effect it's had on them. Do you see what, knowing that they, you know, they're unable, they know the patient, they're unable to get the family, the close person, and they hold the hand, and she said, this has happened sometimes twice or thrice, and the impact that's left on them. And this is some of the issues. So it is difficult on one side, but I think particularly from a healthcare worker who sits there, who's at the side and has to be that person to, you know, for the last person there. I think these are some of the things that we're having to deal with. And I think, I mean, I came in late, but the little that I heard, what I heard from Dr. Prabha, I think is celebrating life in these type of areas are what we have to look at, I think, and presume that. But again, this my story of what I'm telling you is bringing in what some of the nurses are talking, which brings that model, you know, guilt, shame, all these type of things that have happened, and some of them are reflecting now. They become positive, right? So this is what has happened, and they then are now in isolation, in quarantine by themselves, and are reflecting on what they did and how they were with the patient till the end, without them being isolated, and now they are in terms quarantined, isolated by themselves because of being diagnosed with the positive. So it's amazing how the impact it has. Shabir, you might add to this, Shabir, Dr. Shabir, your perspective.
Thanks, Russell. Thanks, Prabha. Yeah, I agree. And you know, this really is uncharted territory. But what it has done, I think, COVID has actually leveled the playing field. And I think as physicians, we really have to recognize, like Derek said, the perception of empathy is just as important. Derek clubbed two words together. He said empathy trumps. I would separate the two words in this context that we live in. But I honestly believe that unless the person believes we are truly empathic, they don't really believe us. So I really agree with that point. And what Prabha said is true. It's very practical. And I was looking at one of the messages by Vatala Swami. It's a beautiful one. He said, we had a memorial ceremony in which the friends and relatives spoke about the deceased person on a Zoom platform, and the family left as if they were with everyone. It was a very nice thing. I think that's very creative. So Russell, we may want to look at how these creative solutions actually should be taught amongst us as physicians to help facilitate that. Even nurses, I agree. Thank you.
Well, one of the things, I guess, I don't know, Zin Bidin, our colleague, Professor or Major General Zin, are you available? I could see you there. I would like to ask you, Zin Bidin is he was the Dean of the Military Medical College, and I wanted to ask, since mortal injury was well known in the army or in the battle, what was his view. I don't know if he's Professor Zinbrin, are you available from Malaysia, from the defense? Are you able to join us? Okay.
Is there? We'll just wait.
Yeah.
Professor Mary, would you like to comment or ask any questions from our panel?
Where is Dr.
No, I thought Professor Russell, you wanted to bring in Professor Jean.
Yeah, I don't know what's happened. I can't find him. He's not there. He wrote me saying that he wanted to join us, but I haven't been able to find him. Professor Jean Futros is a psychiatrist from Lyon, who's also part of our program in France, and he wanted to bring in his aspect of what he's seeing and doing, but unfortunately I can't find him here. Anyhow, yeah. The other one would be probably Harishchandra, Dr. Harishchandra Gambhira from Sri Lanka.
Yeah, he was there till just now. I'll just see if I can.
Okay, this is a good. I mean, I think the other psychiatrist, Dr. Michael Shapiro. Do you want to come in and comment? He's from our unit in the University of Florida in Gainesville. Dr. Shapiro, Michael Shapiro, would you like to offer your from the Department of Psychiatry? Yeah, Michael, are you?
Yeah.
Do you want to?
Hi all. Can you hear me?
Yes, I could hear you. From Professor Michael Shapiro is from Florida, from the University of Florida.
Yeah. Can you turn your video on, Dr. Michael?
Oh, okay. I have very early morning here in the United States, but I'll do it.
Yeah, that's
okay. All right. Thank you.
I appreciate everyone's discussion today. Part of the reason I joined is we had sort of our own ethical and moral distress last week, as so we have a child psychiatric hospital unit in our main psychiatric hospital, and we had our first COVID positive teenager on the unit, and we thought we actually were not going to have any because the adult part has all of their COVID positive patients in the medical hospital, but apparently our pediatrics hospital does not have a COVID unit set up yet, which is its own issue. But we had some concerns over whether we should inform other patients and their families that we had a COVID positive patient on the unit. And that was a lot of discussion that I think normally we don't think about informing other patients' families about a potential risk with their kid being in the hospital. And that was causing a lot of dilemmas among our fellows and our staff. And since they were on the psychiatric hospital, there was also some concern about how do we isolate this person. So the plan was to have them stay in their room, give them a mask, give them a tablet, an electronic tablet so they can communicate. Someone would go in and check on them. But there was a concern about what if somebody does not voluntarily isolate. And the hospital legal department gave us permission if we needed to use both either forced seclusion or restraint if we needed to. And we all felt very uncomfortable with restraint. And there was a lot of stuff about what we can and can't do. And then we had to meet and figure, well, what should we do and what should we not do? So the kid was only in our hospital for about 2 or 3 days, actually. But we ended up meeting Friday to discuss what to do because we think this is not going to be the last time we have a COVID positive person on our unit. So Dr. Joe Thornton, who's actually the head of our unit, and I led a discussion with our child psychiatry fellows and faculty Friday during lunch.
And we sort of worked out our own ethical concerns with this and sent a message to our hospital leadership, anticipating this is going to happen again and what we should be doing. I think we all felt somewhat better for feeling proactive, that we discussed all the ethical issues and we had some good articles to help guide us. And I think what a lot of people are suffering with the moral injuries is that not always feeling like people in position of power or leadership are doing what we feel like would be the more ethical thing to do. And I think it's a big burden on people to see the people who have the power to be more ethical aren't doing that. So that's what I wanted to say.
There you go. Thank you for that.
Thank you.
Thank you very much, Michael. And yeah, we know it's early morning for you. And I guess the other, maybe I should be asking Dr. Professor Sakya from Nepal. You know, you've been, do you want to comment on that from Nepal, Professor Sakya? From Professor
No, I don't think he's
no, he's there.
He's there.
Yeah. Dr. Sakya, do you want to? No, okay.
It doesn't seem to be on, Dr. Russell.
He's there. I just saw, but he's not
No,
here.
his name is there.
Then he's Sakya is a psychiatrist from and the head of the Nepal's unit. Anyway.
Yes, he's there. He's there, but his mic is on, video is off.
Yeah.
Namaste
Yes.
to all.
Okay.
Thank you very much for
what's going on. Okay, anyhow.
Yeah,
we can hear you, so please go ahead. Yeah. Dr. Sakya, please.
Thank you very much. So especially in the resource constraint situation, Nepal, resource is a really constrained one. So as a discussion going on, in Nepal also very much a similar situation is there. Situation of moral injury is very much prevalent. So for the frontline workers, since there is a very less facility, even including this PPEs like that, basic needs also, but in that situation also they have to provide their service, and in that situation also people are actually forthcoming and they are trying their best. So in that state, of course, there will be the conflict situation, and in that, how to go ahead? That is a really very important question for all of us, and that is true for the situation like when there is somebody is dead already, PCR positive come, and the different facilities are very, very less. So in that situation, conflict situation, we have to look what will be the appropriate way. And the same thing written in the book might not apply in all the conditions. In that state, we'll have to have a discussion and then look for the way out. And so with the understanding between the all parties involved might show us what would be the appropriate way. In Nepal also, and this rate is increasing, and for all the people, the situation is really a difficult one. In such a difficult situation, all will have to think what would be the appropriate strategies. And I think about this mental health effect also, we'll have to, all the stakeholders need to be, have to think. And of course, with all the challenges and the problems, there will be a way out. And in that, in this COVID situation also, we have to, think a lot. And especially in context of Nepal, so this resource constraint, basic needs are very less. And in that situation also, we have to work. So it is really a demanding situation currently. And in such situation, So like how to go ahead ethically is also another great question. And so in that situation, we all have to contribute from their side. So I think I would say this much for now.
Thank you, Dana. Maybe an opportunity before we finish, Professor Zilberin. I was looking for you. We have the Dean, Lieutenant General, who was the Dean of the Defense Medical College in Kuala Lumpur. You know, we are talking about moral injury, and usually it comes from the battlefield. This is the first time that we are actually experiencing this in this pandemic and learning so much more about its impact on. What's your thoughts about it, Professor Zimber is the head of the center with the dean at Malaysia, Kuala Lumpur.
Thank you, Prof. Russell. It has been a very interesting presentation this time, very insightful. With regard to moral injuries of the healthcare workers in combating infectious disease and comparing it with moral injuries in the battlefield, I think it's a different situations altogether, because in the battlefield you see mass casualties, soldiers dying, evacuations not being done, treatment not given, and you can see the enemies and the weapons being shot at you. Whereas in this infectious disease, I think we do not see the weapons. You do not see massive casualties dying right in front of your eyes. And you are not in a war zone. So I think to compare the battlefield casualties in terms of moral injuries, I really cannot tell what are the similarities and the differences. Thank you, bro.
Thank you, Professor Zimberin. Thank you very much for that. Okay. And so if that's all, we'll ask Dr. Shabib, do you want to add the final, and we will close our session. It's important, I want for all of you who are still here with us, we have the next 2 webinars are going to be very, very important and interesting. It's going to be the interfaith and religion, the impact of the ethical advice and support that interfaith and religion will give to the community in mitigating the effects of COVID. And this is with the Religions for Peace of the United Nations. With this, we have Professor Des Cahill here with us from who's the chair for Australia for the Religions for Peace, so they're going to be joining with us, many of them and others. So we have many religious leaders as well as interfaith and scientists, and we'll have a discussion on this aspect of dealing with COVID. So that's for all of you. Sabir, would you like to, before we end, I'll ask, well, before I thank you, you might like to say as the lead, your final words before we
Yeah, thank you, Russell. It really was a joy to share the same platform with Prabha. Sujay, we go back a long time. Rajiv, unfortunately, was not. He sent his letter of apology. He had some technical difficulties. Thank you to Russell, Mary, Derek for giving a platform in which we can discuss issues that are not, it's not that we don't discuss it, it's just that we don't have the luxury of discussing it within the context of having so many people who contribute. And the questions were actually lovely. It was a wonderful session for me. I thoroughly enjoyed it. And I'm grateful to Prabha, Sujay for having accepted it. And Russell at the last minute for talking about an area that I think is going to grow, the whole notion of moral injury and post-embitterment. I'm hoping next session he can enlighten people on it. Thank you. Thank you very much.
All right. Again, Dr. Prabha, where is Dr. Prabha? Thank you, Prabha. It was I'm delighted and very nice and honored to have you on platform. We have had in the last 20 some of the leaders from all over the world, and I'm delighted you've joined that group or international panel stretching from around the world, from every part of the world, put it like that. So we'll be there. I want to thank Shabir for putting this together with all his thoughts and so forth, and Dr. Sujay. Thank you very much. I'm sure Rajiv will be there. And I'm also delighted that we had in our company here many from all over the different parts. So we just saw, had the opportunity to have Michael from Florida and Zin from Zinbin from Kuala Lumpur, and from our Shakya from Nepal, but several others of our colleagues were around. Harish Chandra from Colombo and from UK and so forth. They were all here. So it was a great demonstration of solidarity, I think. And so once again, thank you all. Thank to Dr. Mary and to Derek, and I'll hand it to Dr. Mary to have the final word. And Derek, you already, you both.
Yeah, but thank you, Dr. Russell. But before Dr. Mary gives us the final word, on behalf of all the participants, I think they really deserve a standing ovation. Of course, we're not going to stand, as Dr. Shabir said, in this online world, but really outstanding is the least of the compliments that I could give. Dr. Prabha, Dr. Shabir, Dr. Sujoy, so beautifully presented, even though the time was short. I think you all got the message home, and that was absolutely, the participants loved it. So probably one of the best sessions that we've had. Dr. Mary, please.
So thank you, all of you. And just to say that we've learned a lot. This is a platform where we are learning every day. And every webinar is really insightful and very knowledgeable. And we are so privileged to have such eminent speakers coming on this platform and discussing issues which are so relevant today. And thank you to Dr. Prabha, Dr. Sujoy, and especially Dr. Shabir. And I hope we take back, of course, Dr. Russell also. And I hope we remember to be positive. And that's very important in situations like this, that we remain positive and continue, because our profession as healthcare workers by itself is difficult, and the pandemic has made it even more difficult. So thank you once again, and I thank my team, Derek, and of course Dr. Russell, and we hope to meet all of you next week, because we have very interesting discussion on the role of religion at the time of COVID, in this COVID pandemic. Thank you.
All right, and yeah, I'll thank everyone. And I was looking for Des Kyle, Professor Des Kyle here, who's with us, is